Բարև ձեզ հարգելի գործընկերներ, ինձ համար այսօր առանձնահատուկ պատիվ է այս դահլիճում ողջունել մեր գործընկերներին, Aurora մրցանակաբաշխության մեր կազմակերպիչներին, հիմնադրին, պարոն Ռուբեն Վարդանյանին, ում ներկայությունը այս դահլիճում եւս մեկ անգամ վկայում է, որ մեր աշխատանքները այս ոլորտում ունեն համակարգված եւ հետեւական բնույթ եւ անցյալ տարի Թոմքատինայի այս դահլիճում պատվավոր բժիշկի, պատվավոր դոկտորի մեր համալսարանի կոչումը ստանձնելը վկայում է, որ մեր աշխատանքները իրականում գտնվում են առանցքում համալսարանի եւ համալսարանը հետամուտ է իր որդեգրած քաղաքականության աշխարհահռչակ բժիշկներին, առանձնահատուկ մեր շրջանավարտներին, մեր հայրենակիցներին հրավիրել եւ հնարավորություն տալ, որ ուսանողությունը մեր պրոֆեսորադասախոսական կազմը ծանոթանա այսօրվա ձեռքբերումներին, այսօրվա համաշխարհային մարտահրավերներին առողջապահության ոլորտում եւ իհարկե տեսնի այն կերպարներին, որոնց ուղին փայլուն վկայում է նրանց նվիրվածության, մասնագիտությանը, մարդասիրությանը։ Եվ այսօր մեր հյուրն է Aurora մրցանակաբաշխության եւս ավագնորդ մեր լավագույն հայրենակից աշխարհահռչակ վիրաբույժ, որը ճանաչումը ստացել է իր էնդոսկոպիկ, լապարասկոպիկ վիրաբուժության ոլորտում, ռոբոտիկ վիրաբուժության ոլորտում, նաև մեծ ճանաչում է բերել իր երկրին համակարգային փոփոխություններ իրականացնելով առողջապահության ոլորտում, իբրև նախկին Մեծ Բրիտանիայի առողջապահության նախարար եւ այսօր Համաշխարհային ինստիտուտի ինովացիաների առողջապահության ոլորտում այդ ինստիտուտի ղեկավար։ Մեզ համար առանձնահատուկ պատիվ էր, երբ բժշկական համալսարանի մեծ գիտխորհուրդը միաձայն որոշում ընդունեց Մեծ Բրիտանիայի լորդերի պալատի անդամ պրոֆեսոր Արա Դարզիին շնորհել Երևանի պետական բժշկական համալսարանի պատվավոր դոկտորի կոչում։ Խնդրում եմ հապացանակ դոն։
Thank you. Thank you very much. Rector, Your Excellencies, distinguished guests, ladies and gentlemen, I've never been dressed and undressed so quickly. It's a great privilege to be at the Yerevan State Medical University at a momentous weekend, which is a weekend in which we're going to be celebrating a very important humanitarian cause which has been championed by the Aurora Humanitarian Initiative. It's fantastic to see Ruben here, who was one of the founders, his leadership, his passion, which I'm also very privileged that he asked me to be part of the selection. And in most of these meetings, you're always struggling. How do you differentiate who is better when it comes to humanitarian cause? And I'm sure every one of you here have made a significant contribution in this, but it's always wonderful to be here around the celebrations in the next 2 or 3 days, and really reminding us that as mankind, we have an important role to play in a world that is continually challenged. And I could tell you, in a world that I feel, certainly in the last 12 months, we're in a difficult place. The more we express a humanitarian contribution in our everyday life, the better this world would be. Now, it was interesting to see that the Vice Chancellor of the Yerevan State University is called a rector. My university is the only university in the UK that had the title of a rector. The reason for that is the founder of Imperial College was a German, obviously, Prince Albert, Queen Victoria's husband. And as most universities, including the Yerevan University, one of the main roles for the rector is to fundraise. So I remember one fundraising campaign that our previous rector was doing in the United States, where he was introduced as the rector in a big fundraising event. And one person turned around and asked him, they couldn't link this up, and asked him, which church do you actually work in? Because their perception was that he might be a priest. So we now have a president. Sadly, we moved on to the American system. So let me tell you something about the basis of this work. This is my own work, working with some very, very bright and intelligent people. And this starts really with my own history. Armenian. I was born in Baghdad, as most of you will know. My father was an engineer, and I was supposed to be doing engineering in my life. You know, you always follow your dad. And in most Armenian families, there are three professions you can do in life. It's either an engineering, or a doctor, or a lawyer. And I decided that obviously I didn't want to be doing lawyer, because I could never understand what value they add in life. Then I thought about doing, obviously, engineering. So I was about to get to engineering school, and then for some reason, and you always get this son and father tensions, I wanted to do something different. So I ended up doing medicine. I finished medical school and soon realized that in actual fact, my true heart was on engineering. And I joined Imperial at the time I enjoyed St. Mary's Hospital Medical School, which was a standalone medical school. And at that time, some very interesting thing was happening, because the medical school was taken up by the university, and the university was Imperial, was only science and technology only, and the two merged, and I just happened to land at the same time as this happened. And all my work was purely to build the collaborations between the two, and really to do this whole interdisciplinary research, which nowadays people are describing as convergent science, which is the belief that most of the scientific discoveries that we're going to be looking at in the next couple of decades is usually done at the periphery of the stem cells of the scientific disciplines, whether that is engineering and medicine, biology and data and analytics. And I think some have described this, certainly in the US, as the third revolution after molecular biology, after the genome. And I think that's, if you like, is going to be the cornerstone of my talk today. Imperial is a well-known university of science and technology. Some have described it as, if you like, the MIT of the Europe. And it has one of the certainly top scientists that I've never ever had the fortune to meet. And when you talk about interdisciplinary research, it's quite important that you understand the language, the culture, because there is a very different cultures, as some of you may have noticed, between different schools. The School of Engineering has a very different way of doing things rather than the actual School of Medicine. So some of the STEM platforms which we try to really integrate into biomedical research, areas of engineering, physical sciences, and I'm going to share with you some of the exemplars of this work in the department, whether that happens to be wearable sensors, post-surgical monitoring, computer-aided surgery, and that's really been the, if you like, the underpinning science platforms in many of the translational work that we have done in medicine. Firstly, the omics revolution, that is biology. What's the relevance of that in surgery? I will describe that to you. Robotics, although the robotics have been around for the last 15 or 20 years, and there's been a huge expansion of that, interesting enough, the current robotic systems that we have, if you really look at the true evidence base, there is very little evidence out there that in actual fact it adds any value. The only value it adds, it's a marketing exercise for most hospitals who want to do more of this operation or the other, implementing robotic surgeries. On the other hand, there is no question robotic surgery is very much, if you like, we're looking at the tip of the iceberg. As Henry Ford once described, you can buy any car as long as it's black. I suspect robotics in the last 2 decades is the very, very early phase of it. But if you look at what's happened in the marketplace, in the United States, for example, you can see the growth in the number of robotic machines sold across the globe. And this is one of the main winners in this field, which is the Da Vinci, which is a major company in the west coast of the United States called Intuitive Surgical. So when the robot arrived to the operating theater, there were a number of gaps that we identified from a surgical perspective. And some of our early work in robotics surgery was, and this is, some of you probably will recognize this image. This is a patient having a robotically assisted cardiac surgery. These are the robotic arms, as you can see. This is the heart, which is beating. And instead of making a big incision, we were making small incision. Obviously, that was, if you like, the way of doing robotic cardiac surgery. What we realized is the trauma of the surgery isn't just the incision. Actually, in fact, the biggest trauma that you can inflict on a patient during cardiac surgery is when you put them in a heart and lung bypass machine. The cognitive impairment that you see after surgery is mostly related to that. So the challenge to us, could we do the actual bypass without putting a patient on a heart and lung machine? In other words, asking a surgeon to do very fine microscopic stitching, okay, without stopping the heart, which is a very difficult thing to do. You're talking about, tiny sutures, tiny needles, and you have a beating heart happening at the same time. So some of the early work we did was based on the concept of what we call the gaze contingent motion recovery. The surgeon usually sits on the robotic arm, and you can see we have managed to have a tracking device as the surgeon is looking in the control, and we track the movements of the eye. Whenever we look and visualize, as I am now, we have conversion points, and the conversion point is where the fixation point is, where you actually are looking, and then the rest would become peripheral. If you could measure that, which is the technology we introduced, by shining a laser into the eye and then capturing the depth, you can actually, by looking at the fixation point, at least you can calculate the depth recovery. The second thing we did was just to using different imaging modality tools to look at the tissue characteristics. And in here, you will see the video where we will, if I could click that, where you can see that the surgeon is operating using the left eye, this is the right eye. We're capturing the depth, and we also know the tissue characteristics, and we're calculating that with a very simplistic algorithm with a degree of machine learning, and then after that, we will then get the actual reconstruction of these images and the recovery of the depth, as you can see here, and then get the telescope to move, as you can see, the endoscope itself to move at the same speed as the beating heart. So you can see the actual scope moving as the heart is beating. So as the scope moves at the same speed as the beating heart, you can actually display a static image of the heart. This is a bit like being on the motorway, driving two cars, one along each other. One car is, and then suddenly one of your kids in the back and say, "Are we not moving?" Because they're actually looking at the relative motion of the car beside them. So this was one of the first introduction of really helping a surgeon to do a coronary artery bypass graft using robotics, but without actually stopping the cardiac, which we obviously know is one of the main causes of surgical cognitive deficit. The second technology which we developed at the time, which really was an important one, especially if you work in an anatomical area where collateral damage could be significant, like operating in the pelvis, and you have what we call the hypogastric nerve during prostate cancer surgery. You don't want to render a young man with a prostate cancer who you may be curing, render them impotent or incontinent, and the ability then to map out before the operation what we call the green zone. The American Army uses this word quite nicely. During war, the green zone is the safe zone, and you can map up the green zone in the operative field in the pelvis to essentially, even if the surgeon wants to leave that area, they can't. That is the safe anatomical area to operate in, rather than going laterally and divide one of the nerves. So that was what we call a gaze contingent force control or a haptics control. I thought of introducing it in Parliament one day to make sure that politicians don't go beyond the scope of what they do, but sadly, despite that, we have Brexit. So coming into other areas, which is the use of imaging, as you can see here, what we're trying to do is a partial nephrectomy. In other words, why remove the whole kidney if there's a small tumor? But the problem with that is when you're operating robotically or even open, you can actually see the tumor because it's a small little tumor in the middle of the kidney. But the ability to use the images you have preoperatively, reconstruct them, display them during surgery, will allow us to do what we call a partial nephrectomy. In other words, removing half of the kidney rather than the whole kidney. So, the other areas of work, and these are the examples what I've talked to you about, is bringing computer sciences, engineers, physicians, clinicians like me, academic clinicians, translational centers, clinical trials, and really driving these different changes. Access is another area. In other words, how do you get access into the cavities in the abdomen, into the chest, without making incisions? I'm going to share with you some of the technologies we developed there. What are the ways in which you can image new modalities of tissue characteristics using fluoroscopy, for example, in tissue diagnosis intraoperatively, in other words, during the operation, and finally targeted therapies. I'm just going to go through a set of other areas, those in the room who have a great passion about technology. There are huge gaps out there in surgical practice in all aspects of healthcare. This is one area which is what we call a transanal endoscopic microsurgery, which is essentially going through a normal orifice and being able to remove this device, which is called the micro-IGS, which was funded by the Wellcome Trust to the tune of £3 million. It's just about to be introduced into the operating theatre. We've done our first early pilot studies. While we're doing that, instead of making an incision, we go straight through the mouth or through the anal canal to do major surgery rather than just purely an endoscopy. Other areas that, again, combining engineers and material science is the development of this thing called the Cyclops Robot, which is essentially a sheet that goes on the flexible endoscope that we all use in gastroscopy, colonoscopy. Very cheap, very frugal, and what it does, it inflates the balloon at the end of that, and as displayed here, and it has two working arms, and what it allows us to do is to go inside the lumen, say the stomach, and make a full excision of a lesion or a tumor, and then complete the suturing of that. Other areas which are very exciting is in areas of material science, because if you see some of the major innovations in the field of material sciences, what does that mean in surgical instruments and surgical devices? Most of the catheter technologies we have at the moment will actually allow you access to about first or second generation, in other words, in this case being the trachea, into the trachea or the two main bronchus. You can probably reach the first generation branches, but if you have a lesion up here, you need something that allows you to get all the way up there. And these are the newer materials, including those which are hollow, that you can actually introduce a therapeutic agent. This is a small grasper, as you can see in this case, and what it actually is grasping, this here, is a hair follicle. it's a hair, so you can actually see how small this is and how you can actually get it all the way up in getting access to third and fourth generation bronchi to make a biopsy. Other areas that we are using sensing technologies in surgical practice, and this is one great study which we've done in vascular patients. Smoking is prevalent in this country. I'm sure vascular disease is prevalent. But as you know, conservative management, stop smoking, and exercise is the way to get over the claudication issues. And this is a Fitbit, which we currently use for exercise purposes. But this is one large trial looking at the use of Fitbit in feedback to the patients in terms of improving their claudication distance. Another area is sensing that actual fact detect activity of patients. So a patient will have an operation, go home, but they have a sensor implanted on them, and continual monitoring. We can even detect if a patient is deteriorating from their home environment. Some of the ways in which we do that, if a patient has gone home, for example, we know what the normal trend of activity will be post a hip replacement, and that most likely patient will be walking out, but we can measure at home how many times, for example, they visited the kitchen, made a cup of tea, how many times they were lying in bed, and from all of these different parameters, you can predict if the patient is progressing in their post-operative recovery. And some of these sensors, as you can clearly see, you can wearable sensors on the back of the ear, and this is these are, if you like, the different movements and activity that we can pick up in the community. This is the exciting bit, which is the more recent bit, certainly in cancer surgery, is the implantable sensors, and this is the fishhook sensor that we're just about to introduce into clinical trials, which is essentially to monitor response of cancer to radiotherapy. We all know when you do radiotherapy for a tumor, you make it hypoxic. When it becomes hypoxic, it becomes resistant. So the ability to measure tumor response rate is also very exciting. Other sensor technologies are wearable sensors. This is a device that we are now putting on myocutaneous flaps, patients who have a big plastic operations, and we are not entirely sure about the viability of that tissue. So these are new sensors, again, a new clinical trial. We're about to look at this in breast cancer surgery, looking at the viability and the tissue perfusion of a myocutaneous flap in reconstruction of following a fairly radical mastectomy. So other areas which I thought I might share with you is this whole concept of chemistry, biology, and also a degree of physics and its contribution in surgery. This is quite a big program in the department, and it was interesting how it came on. If you happen to be a surgeon in this room, you know surgeons use something called diathermy. The Americans call it Bovie. In actual fact, it was Bovie who discovered this thing back in the East Coast more than 100 years ago. And very common in the operating theatre that the surgeon will cut the tissue using this surgical current. And I've been fascinated by the current for 15 years or 20 years. The reason I was concerned about it because it generates smoke, and I always was worried what's the impact of that smoke on the surgeon. I did a lot of studies about 10 years ago because we were removing certain tumors which were virus-based tumors like warts and things. And obviously there was a risk of infection. We couldn't really identify infective particles in that. So we then came back, revisited the smoke for an interesting point, and I'll tell you the story. One of the great revolutions in breast cancer surgery is moving from mutilating mastectomy into what we call a local excision, a small lumpectomy. But 1 in 5 women having a lumpectomy will come back to the operating theatre, because when the surgeon cuts the lump, they can actually feel the edges. A week later, the pathology will come in and tell you it's at a positive margin, so the lady has to go back in. That means another operation, the emotional trauma of it, cosmesis, infection, delays in radiotherapy. So we thought if this Bovie is cutting around the tumor, if it is positive, could we actually detect tumor cells or tumor-related activity from the smoke? And this is how The knife, which is the surgical Bowie knife, we called it the intelligent knife. And what we did here, and this is an example of the liver, it's showing it, if I could get it to work. This is an animation showing you how it works. So this is the actual diaphragm or the Bowie. You can see we're sucking the smoke that's coming into an extra channel. And we have a mass spectroscopy machine in the operating theatre. Mass spectroscopy machines have been around for 30, 40 years, and this is the first in the operating theatre. So we analysed the smoke to see whether we could find a metabolic profile of a tumour cell. And guess what? We were able to do that with a degree of bioinformatics, in other words, to recognise a computer that recognises if this is negative or positive, and in this case, displaying to the surgeon a red blob, meaning that they're cutting into the tumour, they need to go a little bit further. So the aim here, using an intelligent knife to reduce the number of people waking up with a positive margin. In cancer, the other big area of research at the moment is what we call tumor heterogeneity. At last, we are now recognizing that a tumor isn't the same in all aspects of the tumor. So you can take a biopsy from the middle, and that middle bit, actual fact, has a different signature than the bit at the edge. Number two, we've also realized that with treatment, even the best drugs, it's a bit like antibiotics and bacteria. Chemotherapy in some tumors, the tumor develops resistance to the chemotherapy. It's all part of evolution. It's all the Darwinian theory, is that the fittest survival. So the fittest cells in that tumor will survive, and that's one of the major challenges we've had in really identifying tumor heterogeneity. And this is what we call a DESI technology. One of my colleagues, Zoltan Takis, who's probably one of the smartest chemists that I've worked with, and also his team, Jeremy Nicholson et al., in developing this desorption electrospray ionization, what we call the DESI, where we actually have it now in the operating theatre. We just take a sample of the tumour and put it in. In actual fact, it shows you the tumour heterogeneity, what is muscle, what is a vessel, what is an adenocarcinoma, and that helps you in many ways, certainly in surgical practice, to actually stage the tumour. So you can actually see from the reconstruction of the pathology here, which are the areas of potential margins, but at the same time areas of potential cellular resistance. Moving into another area that I'm delighted to see, again, Aurora and the FAST. Armin is here, and again I have the privilege of sitting on the advisory group on that, is how do we really bring Armenia, or at least build the capacity in Armenia in an amazing revolution happening at the moment in terms of data sciences, analytics, artificial intelligence, machine learning, whatever you wish to call it. All of you doctors who work in this hospital or any of the neighboring hospitals, we know that there are significant challenges in communication between different teams. Historically, that's been a handover with a small piece of paper. But the disruption that we're going to be seeing in digital solutions, which ended up as a startup, and it was bought by an amazing UK company called DeepMind, which really opened up all sorts of opportunities for us in collaboration, in terms of machine learning, and that's resulted in one fascinating area at the moment. We're just about to present this at the American Radiological meeting in Chicago this year, which is looking at raw images, essentially raw data or mammography images in breast screening programs, and getting a machine to develop an algorithm in which you can actually start reporting these as accurately as a human, probably more accurately in the future. And we've done this piece of work by getting access to about 8,000 mammograms. The problem with machine learning, certainly in deep learning or supervised learning, you need to identify, you need to annotate the areas where the abnormality is to allow the machine to learn. And we had a fantastic data set of about 8,000, and that has led us to develop the first algorithm, and then moving into unsupervised learning, in which you can actually use up to hundreds and thousands of different mammograms. So you can see yourself coming into mammography, having a mammogram, and getting the results immediately. Machine learning is having a huge impact in other areas. This is another wonderful couple of papers. This is all happening in the last year or so in terms of detecting diabetic retinopathy, in terms of being able to have a better plan in terms of staging a patient, whether they have lymph node metastases or not. The other one, another wonderful study published again from the West Coast, led by Google, looking at about nearly 200,000 patients having access to their electronic medical record. Again, develop different algorithmic learnings that will help us detect, even alert the physician. So better diagnosis, better care, early detection, you're able to prevent. Other ones are pipelines of pharmaceutical industry, huge interest in this, and again we're collaborating with few in getting machine learning and early drug discovery by having very large databases of chemicals and others that will actually allow us to get through at least early phase 1 trials by being able to tag different compounds, biologics, chemical compounds in terms of their effectiveness from historical clinical trials. Finishing off with another area, I've told you all about hardcore science, is what's the role of design in healthcare? And this is an area that I've had passion about for many, many years. This is our what we call the Helix Center. I decided to employ 8 designers and bring design engineers and bring them in the middle of the hospital, because I recognized many, many years ago that everything we do in hospital is designed around the needs of the doctors rather than around the needs of the patients. Most of the inefficiencies in hospitals are because of poor design. Everything else we do in life, whether it's my computer, whether it's my phone, the design plays a significant component of it. So most of our activity in this area has been in designing pathways of care, designing products. How could you improve the ergonomics of products? Robotics is a good example. It's cumbersome, it's difficult, it takes a while to use. Another area that I was keen in, how could we combine digital technologies, information technologies, and design to improve the ways in which the health service delivers. And one area was in screening. So what we wanted to do, I don't know about the current screening program in Armenia, but we usually in the NHS send the same letter about breast cancer screening to everyone who is eligible to have breast cancer screening. We also know we're very diverse. The letter I get will have a different impact than the letter you get. So the idea here was, could we actually segment the population, understand their attributes, and then try to, if you like, segment the message. You know, an Afro-Caribbean lady at the age of 35 may get other prompt in stimulating her to go screening rather than an individual who might be living in a different postcode in which the triggers of getting them recruited into a screening program would be different. So looking at the message, the type of message, the messenger, we've identified if the individual gets a letter from their doctor for a screening program, the likelihood of them going to a screening is higher than getting a normal routine letter from the NHS, you're due to have screening. We've also discovered that if you actually prompt an individual during their shopping, during evening time, going to do their household shopping, you're probably able to recruit more into the screening program in certain population. We've also started to looking at the ways in which you can recruit, for example, after a church service on a Sunday and getting them into a screening program. So what I'm saying is we are a very diverse population. We need a very different way of approaching the whole screening program. Another area, this is a good example of screening in bowel cancer. The British have this thing about anything to do with the bowel. I don't know what it is. If you go to France, all medications are suppositories. The French have no problem with it. But you come to the UK, I don't know, they're very anal about this, if I could use the word. So we have a problem in screening for bowel cancer. And we spend a lot of time with public and the patients to see why is this problem. Essentially, they don't like poo. They don't like to get a sample of the poo and put it on the test. This is what we call the fecal oval blood. So we designed a stool catcher. This is something small that they put it in the loo, and that increased the uptake of colorectal cancer screening by about 12%. So simple design that you can introduce into the pathway of care could have a significant income. So science discovery, I think, which is what you're doing here. Again, you should look at FAST, because what they're trying to do is to build the capacity of science discovery in this country. I think beside the science discovery, I think a stronger alliances, a university of this size, to other faculties, engineering, physical sciences. Physics is very strong in Armenia. Historically, Armenia has produced many amazing physicists, computer science, and you have to work on the boundaries of these different STEM subjects. Otherwise, I think the technological disruptions that we'll be seeing in the next 15 or 20 years is going to be at the edge of that. And more importantly, let's not forget, a university standing alone as a medical school without working with the hospital, because whatever you take out of the pipeline, if you don't translate, you're not going to create the health value, you're not going to create the economic value. So your translational partner, which is the hospital you're working with, is as important as what you're trying to do. And that's the way in which we've aligned our science base, our translational base, and the standard of care in transforming surgery. Obviously, been very fortunate, a lot of people have invested in us, and I have no doubt there's a huge investment in Armenia too, in getting you to that level of discovery and also back to improving the health of mankind. If you look at the last century, the life expectancy of mankind has doubled, absolutely doubled. And the reason it was doubled is because innovation and technological advances. Interestingly, at the end of the century, the life expectancy has plateaued now. In some countries, it's even starting to drop. So we don't know what is the next thing that is going to push us forward in terms of not just improving the life expectancy, as some people will tell you, we've added years to our life. It's important now to add life to these years. There's no point in living till the age of 100 without actually being capable in doing, or at least exercising, all your faculties. On that note, it's a great privilege to be here at this special Aurora weekend in this special university and being welcomed by all of you and being gifted by your honorary degree rector. I'm very grateful for that. Thank you.
Professor Darzi, thank you very, very much. Now, not only as a general professor or honorary doctor of Yerevan State Medical University, and it was your first lecture in Aurora. Հարցեր, ինչ հարցեր կան պրոֆեսոր Դարզիին։
This is actually your business in Armenia. And I would like to know if there is a platform. Thank you for very motivating speeches.
Okay. Thank you for this motivating speech, and this is what we've been missing out here for the moment. I would like to know whether there is a platform for multidisciplinary research projects between hospitals, engineers, machine learning, because I've been working in such a project, and I came back to Armenia. Now I'm a doctor physician. But I would like to get in touch with the people who are ready to collaborate around this interdisciplinary research project I'm thinking about. Is there a platform?
Well, the answer to that, I was at the FAST meeting last October. Actually, in fact, they had a wonderful symposium. The greatest brains in the world were there. Again, Armin is here somewhere. You can talk to him. It's really to ignite the interest in this area. The reason I think we've talked about this will be relevant here is because the fuel for this type of research isn't just money, it's data. So whoever has the data is the kingmaker. I'll describe, as some people have described it recently, I don't know whether you saw in The Economist, data is the new world oil. And if you have data, then you're going to be the kingmaker. The algorithms are, you can develop these. It's not, most people are over that. So I think if you can see what data sets you have, and that obviously is based on your relationship with the hospital. So the first thing you need to do is to have an information technology systems that has electronic medical records, it has digital imaging. I'm sure the scientists are available here. I think what FAST is trying to do is to really get you collaborating with other centers and developing capacity. And that capacity isn't the computer geeks that do the algorithms. It's also the capacity of clinicians understanding what that data is worth and in using it. And the nice thing about this is you have an opportunity here of really advancing well ahead of most of us who have significant bureaucratic and regulatory issues when it comes to data sharing and all of that, where that hasn't really reached you here. So you can leapfrog this if you have that opportunity. So look up FAST and maybe you take the leadership on that.
Lord Ara, thank you for a very fascinating speech. I have a question that's a little bit related. I've been a patient many times.
Yeah.
I'm always fascinated by the hierarchical structure of hospitals.
Yeah.
Well, we should probably have more of a team structure. What work has been done in going in that direction?
Yeah, it's a great question. I think probably there's a lot of that here as well.
I repeat it again. I think most hospitals are extremely hierarchical. I remember that I was, personally, I was operating some years ago, and I wanted to ask the question to the surgeon, to the professor. The nurse didn't dare to ask the question to him. So I had to wait a day before he finally had the nerve to ask the question. In the meantime, I was not in very good shape. So it was actually a very personal thing. But it's an issue because recently, 2 days ago, I think, or 4 days ago, there was an article in the New York Times about how to go more to a team structure. And I think, and of course, also very culture related. When you go to any in France, it's very hard to talk to the professor. It's a very difficult thing. In other countries, I have a student of mine who is digitalizing the system in Sweden. He's trying to change that system a little bit. Anyhow, I'm not a specialist in it.
No, it's a fantastic question, and I think we've done a lot. I have personally done a lot in this field. I think you're talking about power. That's what you're talking about.
Exactly.
And, it's about shifting the balance of power from the great professor. Actually, in fact, if you go to Germany, some of these guys are as close as God in their power. And how do you shift that power? Because medicine, with the complexity I've demonstrated to you today, is a team sport. It's not one individual. I cannot do this on my own. It's very simple. In actual fact, if you ask patients, 80% of the care they receive isn't me, my own patients. It is from the nursing staff around them. And unless we take that power away, and we've done that successfully in the UK. The idea, I remember when I first started with my boss and the power they had, you have it's a very flat structure now. Obviously, there is accountability too. We still have the system in which if a patient is under the care of me, I am the accountable person. So we need to make sure that although we have a distributed power, we don't lose the concept of who is in charge when you walk in there. And that's a very important, who is in charge in terms of that care. But That's a very important thing. I have no doubt there is that issue here. Less in the US and the UK now. Germany still has it. It's getting diluted. Southern Italy is an interesting one. In actual fact, it's a bit like a royal family if you're the professor of surgery, because if your son inherits the chair. I just couldn't believe that, actually, but there you are. Even if he has two left hands, he still will become the professor. Yeah.
Thank you, Professor Darzi. Very impressive presentation, a dizzying array of phenomenal ideas. And obviously you were fortunate to have this thing for engineering and ended up being an innovator physician. And so with the world going very fast in the direction of integrating those two, do you think the traditional educational system in Armenia should start tweaking those things and developing new physicians for the 21st century, developing knowledge base, actual knowledge base for engineering and other areas of innovation?
It's a great question. You can change the world without actually building the capacity in the areas of change you're looking at. And I couldn't agree more. We're talking about, in many cases now, programs of training which are hybrid. Clinicians understanding chemistry and understanding the jargon, understanding how things work. And we have been successful in few. I had to learn this myself, which wasn't an easy thing to do. It's not just the language, it's the culture. How do you work in these different environments? And the answer to your questions is absolutely. We need more hybrid training in the future, but that's difficult because when you come to universities, which are very, very powerful, I've always been very, very critical of undergraduate medical schools, including my own, that we are producing doctors at the moment that are not fit to the innovations that we are. Technology is moving faster than our training program. It's not keeping up. But you all know in most universities there's a degree of conservatism. Change is challenging, change is expensive, and so we need to find ways. In actual fact, I have encouraged the National Health Service, which actually employs most of these doctors, to have a more better say on the university, say, that's not the product I'm looking for. If you go back in history, the Mayo Clinic created a medical school. Do you know why? Because they weren't happy with the doctors coming from other medical schools. They were a hospital. Okay, we're going to create our own medical school because we're going to train doctors that we need.
One question, and I'm very sorry, one question from here, and then the student questions, okay? Just don't forget that we are in a medical school.
Thank you so much. It was really fantastic, and sometimes it's really big story to understand how humans being brain, what we can do in reality if we learn all our efforts and intersect all efforts of engineers. But let's come to the ground, and the question is how much all these technologies affect this healthcare spending?
Sure.
Because it's a critical point. It's a critical point everywhere, but it's a special critical point for Armenia. Yeah. Because in Armenia we have, for instance, our spendings like global competence less than the United Kingdom. The United Kingdom spends about 10% of GDP. Approximately, Armenia is much less. And our per capita spending is about 20 or 30 times less than the UK. So how much it affects healthcare costs, and what implications for Armenia we can have from these technologies? Thank you.
Thank you for that. Obviously, having the Deputy Minister of Health here should be thinking about this. This guy is very expensive, what he presented. All the doctors are going to be looking for these little gizmos and tools. And so the answer to your question, you're absolutely right. To be honest, it's not just Armenia. All healthcare systems are strained, all of them. We spent 8%, 8.3%. I'm just about to publish a big paper next week, what we need to do in the next 10 years. But, we need to find ways. The problem with healthcare, if I could, is when something new comes into the system, the old is not decommissioned. So there is a big challenge in the healthcare system of decommissioning what doesn't work or what's old. So healthcare expenditure is anything new is an added cost rather than a replacement. So when an innovation is introduced in the banking, which is a chip in the or a pin in the wall or whatever, getting money out, in actual fact, the financial sector saved money by that digital innovation. We need to start thinking in that way. If we are bringing something new, what do we remove from? Second is there are very clear cost effectiveness analysis tools which you can look at efficacy and cost effectiveness either by measuring it through value or qualities, whatever you like. We're moving more towards value. And I think any technology that comes in, you need to demonstrate its value before it's taken up by the health system. Also, do not underestimate, and I'm again talking about this week, in the NHS, if we bring in automation, machine learning, because it's a single payer system, we've done some calculations that we will save the equivalent of 12.5 billion from the NHS's budget. So you could show that, you can demonstrate that, as long as you have a proper diffusion across the system, but at the same time you have decommissioning of some of the old and insignificant. So it's a valid question, but we're always challenged, but there is a price to pay. I mean, at the beginning of the last century, people paid 6 times more on funerals than they did on healthcare. At the end of the century, the average expenditure globally is about 10-11%. The Americans spend 18%, but if you look at their macro indicators in terms of life expectancy, infant mortality, nowhere near what France is, what Germany is, what the UK is. So money doesn't follow outcomes. It's how you deliver the system that matters.
Thank you.
Well, good morning. My name is Ruben and I'm an economist. My father was an economist, so another profession Armenians had a chance to be. I have actually 2 questions, one continuation of the other. First is, you talked a lot about interdisciplinary approach and incorporating engineering and medicine, physics and biology. In Armenia we have 2 separate universities, medical university and an engineering university next door.
Yeah.
So if one wants to start a research like you did in the UK, where should we start? How the world is like in the Imperial College, what's the everyday practice of the research like? And the second question, a continuation, when we have a product, what's the market like for the product? What's the IPO for this product like? Is the hospital, the university works with the first buyer, or there are other mechanisms to sell these products?
Sure. Well, the first question is a good one. I mean, I'm now an honorary degree here, so I could say what I think about the university, could I? Yeah. I think if you're really looking at the future, you need to think through how you collaborate, or at least, I don't believe in mergers because, disruption, but if the leadership of both organizations create the right incentives of bringing people together, even if that doesn't happen, to be honest, when I joined Imperial, no one told me to go and talk to the engineering department. And actual fact, I don't know where you've been in London, I am on the one side of Hyde Park, Imperial College Science Technology is on the other side of Hyde Park. So I actually walked through Hyde Park, 20-minute walk, went in, knocked the door. I had a passion about something, there was a gap, I worked with them, I started understanding their language, explaining it the way they understand. And ultimately what united us, by the way, was a grant. It wasn't the Vice Chancellors, it was a grant. We won a grant together, we started working, and that's how you build up a system. So you could do that. It doesn't have to be in the same university. You can go off and do it, because ultimately both of you, the engineer wants to come up with a new discovery, new patent, you would like to translate that, I suspect you're an economist, you want to evaluate that. So that's one way of doing it. The second question again, sorry, quickly?
How commercialized?
Oh, yeah. Well, obviously, that's not easy. It's not as easy as you think. Universities could set up commercial offices. I think I'm sorry, I've been wearing the flag or carrying the flag of FAST. FAST could be a vehicle that could actually help and advise on commercialization on behalf of universities. Because you need to invest in that area, you need to understand how do you get your patents, how much of these will be startups, how much of these will be loyalties, what's the share to the inventors. I mean, the Americans do this in their sleep. We've done a reasonable job of it in the UK. I think that's not that difficult, but there are certain regulatory issues that you need to, certainly the security of your IP is very important. And I think it's a chicken and egg as well. If people is going to acquire a big industry, then they need to be absolutely 100% on the security of the patent, all the due diligence that needs to be done. So, that's a technical issue. It's feasible. It could be done. Singapore did it very quickly. Actually, in fact, in 10 years, they have a fairly reasonable reputation in the world in terms of their commercialization and their IP registration.
Hello?
Okay.
Tita, I'm sorry, but ladies first. Anyway.
Hello, my name is Sona. I'm a student of Yerevan State Medical University.
Oh, yeah.
Thank you very much for your great lecture and for visiting to Armenia. I would like to know how do you see the future of artificial intelligence use, and especially of blockchain technology used in the healthcare system? Thank you.
Thank you. Well, I think AI is going to have a huge productivity impact. I think certainly some depends on the type of professional you're talking about. Anywhere between 35 to 40% productivity gain. In other words, the ability of individuals to do other things. I mean, the administrative thing, electronic medical records, ordering, alerts, all of that is going to have a tremendous impact in there. I mean, there's this whole fear out there that automation and AI is going to make people unemployed in the workforce. Healthcare is not like the banking sector. There's a lot of touchy-feely connecting stuff that needs to happen in healthcare, so I don't see it that way. The example I told you about diagnostics, there was an interesting paper published recently on pathology in terms of machine learning and human reporting. And if you look at the combination of the two, got the best outcome. So I don't think it's going to displace people, but it's going to dramatically improve the productivity of healthcare professionals working in healthcare systems.
Wow, this is real science, and I'm fascinated by your work. So my question is the following: what is the main key point of your success? And second question is, what would be your advice to, as a former Minister of Health, to the future Minister of Health of Armenia? Thank you.
You seem to have you probably have a gene of a politician. So, what's the recipe? Firstly, and more importantly, go back to the basics. I'm Armenian. I have the same gene pool as all of you here have. We're all reasonably smart in this room. Yeah. We're all reasonably smart. We are very hard workers. We're trustworthy people. If you combine those three together, you don't need to be a genius to do what I've done. That's not, it's a matter of persistent, take what the second founder also of the Aurora Prize, Nuba, and what he has achieved in terms of the life sciences industry and his creativity is just astonishing. So we're all the same, and we just need to have confidence. The only issue is confidence. As you being a politician, you also need some political leadership in terms of stability, in terms of opening up opportunities. and it's all there. I think the other thing is those who left have been very successful. How do we make sure that people here are retained, in actual fact contributing to this country? And most of the diaspora feels very guilty and comes back regularly and take Aurora, take FAST, take all the other initiatives that people are doing. So that's the recipe.
Thank you very much for informing us about all this. As a mental health professional, we know that there is no health without mental health.
Yeah.
Is there any particular message that you would like to emphasize, to convey within these innovative approaches about mental health? Thank you.
Yeah, absolutely. I thank you for asking that. I mean, I could have spoken mental health. I'm very passionate about. In actual fact, I think we have mental health crises at the moment globally, and that's a big, big issue. I think there's and at all levels, in terms of research and development, I think some avenues there are opening in terms of policy. I think the whole thing about awareness of mental health, I think, we've always underestimated the burden of mental health disease, and I think we need to look at that very, very. In the UK, we're getting there. I think the big opportunity in mental health, I believe, is in digital. Many years ago, I worked with a wonderful organization that I managed to get some funding for, called the Big White Wall, who targeted a group of the population which are mostly the worst affected. And that's the adolescents population. Adolescents is 16-year-olds up to. Now those kids, sadly, don't get adult services, don't get children's services, and they usually do not want to see anyone. And the Big White Wall was, if you like, a web-based interface, now digital, that allows you to interact and get CBT through that in the confidence and in the confidentiality and all of that restricted. So I think any policymaker in this country should be considering the whole mental health agenda and have a national mental health strategy. Because even in the UK, or take the US, I mean, mental health patients end up in the emergency department. And that's the last place they want to be in. It has to be nearer to home, primary community. I did one piece of work in London in 2000 and 2014. I looked at the overall expenditure in different categories of disease areas based on age. In London, we have 67,000 people with severe and enduring mental illness. That is schizophrenia, psychosis, the serious stuff. 67,000. We spend, guess how much? 2.1 billion pounds on them. So I decided to go out there, take a sample of the 67,000 based on age, sex, ethnicity, and did random qualitative questionnaire. 90% were unhappy with the services provided, despite that expenditure. So what you need is to redesign the whole package, the whole delivery mechanism, based with the patient. And this is one thing, everyone here is a doctor, young qualifier. Always co-produce the pathway of care with the patient. You will learn a lot from the patient. It's back to the power question, patient versus doctors, is the most successful doctors actually co-design their pathway of care. And we need to move from that paternalistic approach into more a partnership approach. It's difficult. Yeah.
My question is, how can Armenian researchers attract more grant money to conduct research and collaborate?
That's a good question. I think, well, firstly, at a national level, and I'm sure it's easy said, but there are a lot of constraints on the national budget or the exchequer or the chancellors here in terms of putting money towards research. But most countries spend anywhere between 2 to 3% of their GDP on research. So I think it has to start with the leadership of at least putting something in your GDP in relation to science. I think there are now a lot of global philanthropic organizations which are funding research in lower and middle income countries, so Gates Foundation and others. I think certainly the Aurora, FAST, a number of other initiatives here are very keen to link people together. I know, for example, recently I put in a grant with a group from Armenia on the DFID. DFID is our Department of International Funding, which gives a significant amount of research for lower and middle income countries as long as you have a partnership. So you need to develop, if you're a university person here, you need to develop your relationship with other universities in Europe and the US, because most of these are looking for collaborative partnership in terms of helping, in terms of governance, execution, delivery. You know, getting a grant is easy. It's the execution, delivery, and having the impact is the thing. So I'm happy you can write to me. I could link you to a number of different groups who are very successful in funding research.
Last question.
Okay, good morning, Lord Darzi. My name is Dr. Rahul and I'm an internal medicine University at Mendes University. My question is that a few minutes back you said that the competency of doctors is not matching the race of technology, the way the innovation is coming. My question is that what do they, unlike the clinicians who are working for years, are not compatible even after getting those board certifications, FRCS, FRCP, your UK accreditations. Even after that, the doctors are being pushed away from UK, they've been sent back to Norway with lots of different doctors, because I'm Indian myself. So I want to know that these experience, what doctors hold in lots of years of their medical education and experience, would that experience would be lagging behind in the technology, would be given preference for that, because it's been seen that when there are diseases, when we diagnose, it's not the literature. We don't read exactly the things which are there in the medical books. There are things which we learn from our experience, and the treatment which we give with the course of time and experience, right? That cannot ever match the technology, which would be a man-made technology, which would have a fixed knowledge into it, right? So I just want, I got worried when you said that Mayo Clinic is making their own medical schools to have their own medical trained professionals. What about people who are being already into the practice since years? Would they be lagging behind with the technology coming in? That is something worrying, that is something questionable on the future of all who are working and studying medicine in different parts of the world.
Sure. I think the answer to your question, which was a bit complex, is very simple. Life is learning every day. Okay, it's as simple as that. So whatever you've learned yesterday is irrelevant. What are you going to learn today and tomorrow? There's obviously, we work in a fairly controlled regulatory system. What we've done in the UK is introduce this whole concept of revalidation. So every 5 years, I am revalidated. So I need to be presenting all my data, all my outcomes. I need, believe it or not, I need 50 patients write about me to say whether I was good, bad, ugly. I need 50 colleagues to tell me whether I was doing this and that. But at the same time, I think with digital and a number of other tools, we need to make sure we keep up to date. And I think if we come back to another relevant to machine learning, in actual fact, it's enabling me to close some of my knowledge gaps when I'm coming to making a certain diagnostic decision or a therapeutic decision.
I want to say thank you, Ara. Just really, Professor Darzi, fantastic lecture. And I'm so great to be with you together here. But I will say one thing which I'll share with all of you sitting here. I was 3 months ago in EU and meeting the head of the commission who was supporting science and technology. And there were billions of dollars especially dedicated to the science technology. And I asked how many Armenians got this grant. I said 0.
Yeah.
1 from Germany. Which means if the money is available, we all can complain about many things, but if you're not curious, if you're not doing the learning, you're trying to knock the doors like 100 every day, saying whom I can intrigue with my idea, how I can engage somebody who work with me, nothing will change. So I I just want to say that the example of Professor Darzi's success is an example of something that just consistent hard work, but curiosity and open mind to everything you learn. And I think it's just very important for all of us to understand it's money, problems, technology, politicians, there's always excuses. Everything in our hand. I mean, I think the lecture of Darzi is an example of this, and I want to thank you for being with us.
Thank you.
I'm privileged to have you like friend and member of the lecture committee and an advisory board in the FAST. And I hope FAST really can help spread more information, but please don't complain. Try to do something.
Absolutely.
As a hosting university, we want to say you thank you, and if we conclude, especially in your last slide of the lecture for academic area, because we are academics, first of all, we can do everything from molecular up to the transforming into the clinical medicine, and we have this platform, and as Ruben just again tell your mainstream, but we have to be hardworking and we can do it, especially in academic area. Thank you very much.
Thank you.
As a honorary doctor of medical school.